Yeah, it's cool. That certainly,
How are you? Thank you so much. Okay, 2 more minutes. I think time-wise we'll be good. I don't suspect it'll be too long, and if a couple people straggling in, I don't want them to feel like they're interrupting. But. All right, I think we'll go and get started. Can everyone hear me okay? I want to thank everyone for joining me this evening. My name is Syed Mehdi. I'm one of the new orthopedic and minimally invasive spine surgeons here at Freighter South. And today I'm going to give a presentation on some advancements in minimally invasive spine surgery. So I'm part of a multidisciplinary group here at Freighter South that takes care of all orthopedic problems, whether it's shoulders, hips, knees, or the spine, which is my specialty. If there's anything that's aching you, we can certainly take care of you here. So just a little bit about me before we get started. So I'm originally from Mequon, Wisconsin. My family still lives there, so that was a big part of my decision to come back to Wisconsin to practice medicine. After I completed high school here, I spent 4 years in Atlanta, Georgia at Emory University for my undergraduate studies. I then spent 4 years at the Cleveland Clinic in Case Western doing my medical school. Afterwards, I spent 5 years in an orthopedic surgery residency at the University of Kentucky in Lexington. And then I decided to spend 1 extra year doing nothing but spine surgery at Houston Methodist Hospital in Houston, Texas. So I want to make this a little bit interactive, so if anyone has any questions throughout the presentation, please feel free to raise your hand and ask. But I just wanted to start with, who here has ever had back pain before? Right. So it's unfortunately a very common thing that I deal with and that people in general deal with. And one of the major questions I get asked is, well, what causes back pain? And the main source is something called lumbar spondylosis, which is just the medical term for age-related degeneration of the back. And this can be due to degeneration of the discs, which are the shock absorbers in between the bones in our back. It can be due to arthritis in the joints in our back. It can be due to disc herniations, and it can be due to bone spurs or osteophytes. So these pictures do a good job kind of demonstrating what that looks like. Here on the left, you can see this is kind of what a normal spine looks like. There's a nice healthy disc in between the two bones. The joints look nice and healthy. There's no osteophytes. And then on the right side, you can see what happens after we get a few miles on our back. the disc starts to wear down, it starts to thin out, we get bone spurs, the joints degenerate, and this unfortunately causes back pain. The picture on the right also does a good demonstration of what happens as our discs get a little bit older. They start to wear down, they can become weak and bulge, and sometimes they can herniate and pinch the nerves in our back, again causing back pain, and then sometimes causing leg pain. And so symptoms will, as I mentioned, will present usually with back pain, back stiffness, leg pain, numbness, tingling, and weakness down the legs. And the reason that people get those leg symptoms, such as numbness, tingling, and weakness, is because when the nerves in our back get pinched from either a disc herniation or just narrowing in the spine itself, those nerves get inflamed and swollen. And when that happens, they present as numbness and tingling going down the legs. And here in this picture, you can see when you have this herniated disc, it causes inflammation of that nerve. That nerve sends signals down to our legs, and that's why people have pretty bad numbness, tingling, and weakness. This is a little bit more complicated slide, but the basic reason of why our discs wear down is, unfortunately, as a part of aging process, as we get a little bit older, the discs become weaker and they break down. Genetics is a big component of how fast those discs break down. Unfortunately, some people just have some bad luck and their discs wear down faster than others. So family history is a big part of, I see people that their parents had back issues, they're having back issues, so we know genetics plays a big part. Smoking and obesity, we know, are two big risk factors for kind of speeding the degeneration of the disc. So while genetics we can't really control, there are some things that we can try and modify to reduce our risk of those discs breaking down faster. And so, why is this important and why do I still have a job? So, low back pain is, believe it or not, the leading cause of years lost of disability in the United States. It's the second most common reason people go to see the doctor after the flu or the cold. 40% of Americans at some point during the year will experience back pain, and about 85% of us will experience back pain at some point in our lifetime. So we know, unfortunately, it's a very common problem. And the low back pain itself causes the U.S. economy approximately $140 billion a year in time lost to disability and time off work. So it's certainly a problem that's been here, and it's probably not going away anytime soon. And as I had mentioned in the slide before, some of the most common causes of back pain, so arthritis is a big part of that, bulging discs, stenosis, which is a medical term for narrowing around where the nerves exit our back and go down our legs. Fractures can certainly be a cause, muscle strain, and then sciatica, which is, again, another term for a pinched nerve. Those are all, the different sources of the back pain and symptoms we have in our legs. So some of the most common presentations, pain with activity, especially pain that's worse at the end of the day. That's kind of classic for arthritis or disc degenerative pain. Pain with certain motions, such as bending forwards or twisting. All of those motions put a little bit extra stress on our discs, and when that happens, that can flare up the back pain. Sometimes the pain will radiate across the entire back, and then oftentimes I see people that were complaining of hip pain or buttock pain, and so you would initially think that maybe that's the hip joint, but that can actually be pain that's starting in your back and is radiating out to the hips. And again, all of these are primarily due to that age-related degeneration of the joints and the discs in our back. So another very common symptom I see is something called lumbar radiculopathy. So that's the medical term for pain shooting down the leg, numbness, tingling, weakness, etc. And usually, depending on what nerve is affected in our back, the pain will go down a specific part of the leg or the foot. So it may be pain that shoots down the front of the leg, pain that shoots down the back of the leg, pain that goes to the top of the foot, the side of the foot, etc. So depending on the symptoms, it can help me kind of figure out exactly where the problem is starting from. So, how do I address this? So when a patient comes to see me for the first time, I'll do a full history and physical to get an idea of what I think are the cause of the symptoms they're having. And 90 to 95% of people that I see respond very well to conservative treatment, so don't need any type of surgery. And the biggest thing that I recommend is physical therapy for your back. And the idea of physical therapy is they work on strengthening the core muscles and the back muscles in your back. When those muscles are nice and strong, then the discs and the bones in your back aren't holding you up. The muscles are doing all the hard work. And that will help with the vast majority of people. The second step is to use medications like anti-inflammatory medication. So ibuprofen is probably the most commonly known anti-inflammatory medication. The idea is inflammation, the swelling is what causes back pain. If we give you medications to stop the swelling,
It'll stop the inflammation, and that should help with the pain. And then finally, steroid injections are another option for bad back pain and leg pain. And the idea of the steroid injections is we give you that anti-inflammatory medication right at the source of the problem. And like I said, 95% of people respond well to these treatments and never need surgery. But if all of those fail and we need to do surgery, we have options to get your symptoms better. The first is something called a decompression. This is where we take pressure off of the nerves in your back. It usually involves removing either a bone or a disc that's pinching the nerves. And if absolutely necessary, sometimes we have to do a fusion, which I think gets a very bad reputation, understandably, but in the right patient, I think people that get fusions can do very, very well. So in the past, the classic spine surgery involved a big open incision, a big cut on your back. We have to go down, remove all the muscles, cut the muscles off of the bone, and then do whichever surgery is necessary, whether it's a decompression, which is here in the middle, where we're taking the bone off of the spine, or doing a fusion. The problem with open surgery is we have to make a big incision on your back. We have to cut all the muscles off the bone. That can cause a lot of bleeding. When we cut the muscles off the bone, no matter how well we try and reattach them, there's going to be a lot of scar. There's going to be a longer surgery. The recovery is usually longer, and it usually leads to a longer hospital stay. So, while open surgery can accomplish the goals of taking pressure off the nerves, there are some downsides of making a big incision and a big cut on your back. So that leads to the question, well, are there other ways to accomplish our goals of surgery? And that's where the idea of minimally invasive spine surgery was developed. So what is minimally invasive spine surgery? So the idea is we make as small of an incision as we possibly can and disrupt as little of the tissue as possible to accomplish our goals of surgery. And there are special tools and instruments that we use to accomplish that surgery. So in this diagram here, they're removing a disc that's been pinching the nerves, but you can see they're using a nice small tube and special instruments that go down that tube to accomplish the same goal as an open surgery without all the downsides. And this is kind of a better picture of this. So you can see it's approximately a 2-centimeter tube. We use special instruments that go down this tube, and we can either decompress the spine, meaning take pressure off the nerves, or even do something as big as a fusion through something as small as a 2-centimeter incision. And your incision can be the size of a paperclip, and you can accomplish all these goals. So, what are the benefits of minimally invasive surgery? So I told you all the downsides of an open surgery. So if you just reverse it, that's basically the benefits of minimally invasive surgery. It's a smaller incision, less blood loss. We're not really cutting the muscle, so there's not a big recovery. Usually patients are able to go home much sooner and overall require less pain medication because we're not making a big cut. So this is just my anecdote. So I've been at Frederiksberg now for 1 year, and I was just looking back at the patients I've done since I've been here. So through these MIS techniques, 91% of the patients I've done surgery on are able to go home within 24 hours, and 70% of the patients I've done surgery on are able to go home the same day. And this includes doing fusions, which, like I said, has a pretty bad reputation, need a week of stay in the hospital. At least in my experience, with the right indicated patient, I can get people out within 24 hours of even doing a big fusion. And on average, patients only require about 3 days worth of narcotic medication, so not a big requirement for pain medications after surgery either. So now I'm just going to talk about some of the surgeries that I do. So probably my most common surgery is what we call the decompression. So that means we kind of decompress or take pressure off of the nerves. The main goals of this surgery is to help with the leg pain, help with leg numbness, tingling, weakness in the muscles in the leg, and will sometimes also help with back pain. And usually these surgeries can avoid any type of major fusion or instrumentation. And so these two diagrams here are showing kind of the two most common surgeries. On the top right is something called a laminectomy. That's where we remove the bone on top of the spine that's squeezing the nerves. And then the image on the bottom is something called a discectomy. So we remove the disc that's bulging out and pinching the nerves. And this is just another picture of that laminectomy. We take that big piece of bone off that's been squeezing the nerves and give them more space and help with those leg symptoms. So now I'm going to shortly play a video of a surgery that I think I'm the only one in southeast Wisconsin that's doing this right now, but I think this is a surgery that's going to pick up throughout the United States just based on how minimally invasive it is. If you've ever heard of a shoulder scope or a knee scope, we can do a scope in the spine as well. So we use a special camera to look directly at the spine, do our surgery. and the incision is about less than a centimeter. So I've done about 5 of these here at Freighter South. Did about 20 of these in my training, so something that I'm very passionate about. I think patients do great with this. So I'll play this video, and then you can see kind of what this entails.
Nerve pain that extends to one or both legs is commonly caused by degenerative spinal disc disease. This can lead to a herniated disc, a common cause of patients experiencing back pain. For patients with a herniated disc causing nerve impingement or compression, an endoscopic approach is regarded as a highly successful procedure that may bring relief and restore mobility. For a centralized disc herniation at L5 to S1, an interlaminar approach is typically used to access the disc. During surgery, with the aid of fluoroscopy or X-ray imaging, the surgeon will use a needle to mark the proper trajectory from the skin to the disc herniation. A guide wire will be inserted through the needle, and the needle will be removed. Dilators will be placed sequentially over the guide wire to then allow for the cannula to be inserted. Through this cannula, a specialized spine-specific endoscope is introduced to allow for real-time direct visualization of the tissue layer that covers the backside of the spinal canal. A small incision will be made in this tissue layer, or ligamentum flavum, to allow for the endoscope to pass through. Using the instruments, the surgeon will carefully push the spinal nerves aside to protect them and allow the disc herniation to come into view. Through the working channel of the endoscope, small instruments will be used to take out disc fragments of the herniation. An electrocautery tool will be used to cauterize the fibrous outer layer of the disc to prevent future disc herniations. Once the herniation has been removed, the surgeon will bring out the endoscope and may place a stitch or two to close the incision before placing a small bandage. By employing an interlaminar approach to a centralized disc herniation, your surgeon can reduce the risk of damaging soft tissue and muscle structures, and therefore can achieve a lower risk of infection and fewer postoperative complications, letting you return to normal daily activity sooner.
So I thought it'd be useful to kind of show a specific case. Did you have a question?
Is the whole disc removed or just the protruding part?
I'm just going to repeat the question for everyone listening online. So she asked, is the whole disc removed or just the protruding part? So just the part that's protruding out. Because we don't ideally want to take the whole disc out, because if we do, then we have to fill that space with something, and that's when we talk about the fusion surgery. So we just remove the part that's pinching the nerves. Yeah, absolutely. Any other questions? So I thought I'd just run through a case where I used this kind of technology. So this was a 60-year-old patient, was having severe left leg pain and left leg weakness. They had tried about a month of conservative treatment, weren't getting any better. So as you can see here, there's a large disc herniation that's pinching those nerves. They aren't very happy, and that's causing that leg pain and the leg weakness that the patient was having. So just for comparison's sake, this is what a normal level in our spine looks like. All of these tiny black dots are the nerves that go down the spine and exit and go into the legs. They're surrounded by this white spinal fluid. This is what you want to see, plenty of space for the nerves. And here you can see not as much space for the nerves. There's this big disc that's pushing on them, and they're not very happy. So this is a video of the surgery. So this is the view that I have through the camera. Right now I'm just kind of removing some of the muscle and tissue that's sitting right on top of the nerve and the disc. We use kind of this special cautery tool to kind of burn all the soft tissue. That's the hole that we make by just drilling a little bit of the bone. This is the burr that I use, or the drill that I use. It is a special tip, so if you do touch the nerves, it doesn't damage or tear the nerves. So it makes the surgery as safe as possible. And here we're just kind of working on making more space. And then again, we're using that special cautery tool just to make sure that we can get access to the disc. Here I'm just making sure that I've removed enough of the bone to kind of safely access the area I'm trying to reach. And then now this is kind of the best part. This is where we're pulling that big disc herniation out. It's all that kind of crab meat looking material. And then here's another big pull of all of that disc out. And then we have kind of one final pull here, and then in the background you'll see that nerve. That's nice and free now. So we didn't see that before, and now there's plenty of space for that nerve that wasn't there with that big disc herniation. And that's just showing we're able to kind of get all the way to the other side of the spine with this camera. So it's pretty remarkable what we're able to do and what we're able to visualize. And that's the other nerve that's exiting on the side too. We weren't able to see that before too because of that big disc bulge. So now this is kind of our view at the very end. That spine is nice and happy, has plenty of space that it didn't have before surgery. And so just for visualization's sake, this was the incision I made. So that's my finger for a reference, and that's like just about a centimeter incision. And on the right side, that's all that disc material we were able to take out through that tiny incision. So in the past, you'd have a big incision this big, move all the muscles off, get down to that disc, remove some bone, and now we can do it through this very, very small incision. So the other surgery I do aside from the scope is something called a tubular surgery. So we kind of talked about this before. Make a slightly bigger incision, about 2 centimeters, use this special tube that allows us to use specific instruments to get down to the spine and accomplish our goal of either a decompression or a fusion. So this is kind of my view of an artist illustration of what my view is like. So this is us looking straight down the tube. We've removed a little bit of bone right here on the side here. You know, this is that ligamentum flavum that was shown in that video before, and that's the spine right below it. So this is the view that I'm able to see, and we're able to kind of do a lot of work through this tiny working channel. So, you know, one question I commonly get asked is, well, am I too old to get spine surgery? Is it safe for me to get spine surgery? Am I going to be able to recover from this? So I thought it'd be nice to give an example of this patient. This patient is 93 years old. They had severe stenosis or narrowing in their back, as you can see here on the left. Weren't able to walk for more than 100 feet without having to sit down because of severe debilitating pain in their legs. And just for comparison's sake, again, this is what a nice normal level looks like, and you can see on the left, those nerves have absolutely no breathing room. So even though this patient was 93, I felt like there were ways we could make this patient better and get them back to doing the activities they wanted to do. So in this instance, this was a patient that I did the tube surgery on. So this is kind of my view. The kind of these ligaments here with this black arrow, that's what's squeezing or pinching down on the nerves. And this is kind of a reference. So I've removed all of this bone over here through this tube, and now we're looking directly on the spine. And then when I take the ligaments off, this is that nerve or those spines that are completely decompressed, completely free, and I have a ton more space. And this patient stayed in the recovery unit for about an hour and a half, went home the same day. I saw them back 2 weeks later. The leg pain was completely gone. They were back to doing all the activities they were normally doing. So, age is all relative. I think even someone who's as old as 93, we can certainly get better with some of these minimally invasive techniques. So another common surgery I do is a fusion. And a condition I commonly see is something called a spondylolisthesis. It's just a fancy medical term for two bones that have started to slip or shift because the disc between the bones have started to wear down. And as this animation shows, sometimes it can be associated with a fracture in the back. And what happens is when those bones start to shift back and forth, they pinch or tether the nerves behind them. And so patients will commonly present with both back pain and pain that goes down the legs. And so, the goals of the fusion surgeries are to both stabilize the spine, so it's not moving back and forth, and then to also help with the nerve pain because that nerve isn't constantly being squeezed when the bones are moving back and forth. And you can kind of see from this x-ray here, those yellow lines are the fracture in the back of the spine. And then this red gap here is where those bones have kind of shifted a little bit. This bone should be sitting slightly back, but because that fracture is there and the discs have worn down, those bones are shifting. And so patients will constantly have back pain, especially with specific motions like bending forward. Another reason that I do a fusion surgery is if people have recurrent or multiple disc herniations. You saw the video of that disc herniation. That was a one-time event. If that happens multiple times, then we have to take too much of the disc out, and in that instance, the patient has to be fused. And another reason we do fusion surgery is that if the discs are so worn down that they've collapsed and the nerves are being squeezed, the only way to relieve that nerve pressure is to kind of jack open that space, and in order to do that, we have to put a cage and screws to give the nerves more space. So those are the kind of most common reasons to have to do a fusion surgery. So now I'm just going to run through this video. So here at Freighter South, we have a spine robot that I use for all of my fusions. That helps me in planning the surgery, helps me in making my incisions to do this as minimally invasive as possible. So we'll play this video. It's about a 3-minute video. I'll narrate and kind of explain what's going on. And this is the workflow that I use whenever we do fusion surgeries here. All right, so these are all kind of the instruments that we use throughout the surgery. Before we start, I'm able to plan the exact size of the screws I'm going to place. I can plan the exact trajectory of the screws, the exact height, diameter. I can see where they'll be in real-time 3D animation. And this allows me to kind of place the screws the exact same way every time. Once we're happy with our plan, then this robot arm will come in. It'll go to that exact trajectory that I planned. We use these special tools to drill a hole in the bone to start where we're going to put our screws. This is a specific, again, drill that just keeps opening up the space. Throughout the procedure, we use the special navigation. So again, I know exactly where I'm at all times in the spine. And then we place these special design screws that are meant for minimally invasive surgery. It gives me a nice green check mark to know I did a good job. And then once we're done placing all of our screws, we have to put that cage in between the bones that I talked about. So here we can plan the exact size of the cage, the angle it's going to go in, the height of the cage. And then we use a special instrument to dock exactly where we want to go for the surgery. Now I showed you what the tube looks like at the very end, but in order to put the tube down, we slowly dilate the space for the tube. And then once we have that corridor, we put that final attachment for the tube. We can actually put that to the robot itself. Here we're just confirming that we're in the exact spot we want to be to put that final cage in. And then once we're happy with that, we'll lock that tube into place. And then we start with the fusion part of the surgery where we start to remove that disc and place that cage. So now all of our instruments are navigated, meaning we can use the robot and a special CT scan to know exactly where we are in space. So here we're in that disc space. We're scraping and removing all of that disc that we need to before we can do our fusion surgery. And again, this lets me know in real time exactly where I am throughout the surgery. Here again, we're kind of making that final space for where we'll put the cage in. And then once we're happy, we'll put our final cage that will be the big part of our fusion. And again, we can see exactly where it's going based on the navigation and based on the robot. And then at the very end, we can open up that cage, give that nerve that was tight a ton of space. And this is a product that we have here at Freighter South we've had for the last 6 or 7 months. And fortunately, I'm able to use kind of for all the fusion surgeries that I do. Yes?
What size about is the cage?
So the cage will vary. It's usually 30 millimeters by 20 millimeters. It's not a very large implant. It's basically the size of the disc space that each person has. So it varies, and we'll measure the disc space for each individual patient. And based on that, we'll plan our cage size.
So this is a lot different from years ago, large cages with like stripping things on the side. A nephew of mine had surgery many 20 years ago.
Yeah. So fortunately, with our development in kind of 3D technology and the way we're able to design our cages, we've known that we don't need as much kind of fill of the cage. We don't need all the kind of previous instrumentation that was required to get the fusion. And so that's part of the benefits of these robotic surgeries. I can plan exactly where the cage needs to go and how big it needs to be. And so we can individualize a surgery for each patient. Yes? In this MRI or in that video? Yeah, so the facet joints will be these structures back here and here. So each level in your spine has 2 facet joints. Yes?
In the past, did they take a piece of bone and use that as part of the fusion also?
Correct. So in the past, before we had titanium cages, we would take a piece of your own bone and put it in that space to get the fusion. The one downside was a lot of people would have this big back surgery, and the only thing they would complain about would be that where we took that bone graft from. And so we've done a lot of studies that look at, is the fusion rate the same or worse if we do a cage versus your own bone graft? And what I do in my surgeries, instead of taking your big bone graft, I take some of your bone marrow during the surgery through a special needle. I'll spin the bone marrow down so we still have all those good cells, and I'll put that in the cage to help your fusion. And we've seen that studies show that the fusion rates are the same. So it saves another kind of part of the procedure, not having to take a big piece of bone out of your hip to do the fusion. Any other questions? Yes? No, so fortunately now, this day and age, the titanium cage, there's a lot of studies that show that it's equal or not better than the PEEK cages we had in the past or the bone grafts. So there's been really no issue with getting titanium cages approved.
Mine was not approved. I had C567G1, and they would not approve the titanium cage.
Okay. Did they give you a specific reason why?
None that I'm aware of.
Okay. Yeah, I'd be interested to see why, because fortunately I've not yet had any issues with getting those approved. No. Other questions?
Will any of these procedures help if you have arthritis in those facet joints?
So yeah, that's an excellent question. So.
I had a couple of ablations.
Mm-hmm.
If I understand it right, and I might just have a very simplified, it kills the nerves, then they grow back and
Yep.
I'm in pain again.
Yep, so the nerve ablation, exactly like you said, they burn the pain nerves. That is one downside of the procedure, is nerves will regenerate, so they can come back. You know, there is a procedure where we can, instead of burning the nerves, we can cut the nerve permanently so it doesn't grow back. Especially if patients have responded to nerve ablations, that is an option, especially with, we can use those scopes as well, so that's an option. We don't normally fuse for just facet disease because you can have it at multiple levels. And the last thing we want to do is do a big fusion in your back for back pain. And we know, unfortunately, there's a lot of studies that show doing fusions for just back pain, patients do the same, if not worse, than if they didn't have a surgery. But for facet disease, where an ablation has helped, there are ways to do that scope surgery where we go down and we burn that, or we completely cut the nerve. So that is an option. Yeah. Yeah.
And then, do you do anything with the arthritis that's in there? But I've also heard too that if you go in there, it can make the arthritis just.
Yeah, so yeah, and that's a little bit of the nuance of spine surgery, right? People will have arthritis to some degree throughout their spine. The goal is to try to address, one, the level that's most symptomatic or the level that's causing the most problems, and try and limit as much as we can when it comes to fusion, because I see a lot of people that have arthritis in their entire back, but the last thing I would recommend is we do a big fusion in your entire back. So a lot of that will be the nerve ablations, injections, medications, other things to try and calm those symptoms down, because the vast majority of people, even from having arthritis in their back, will improve with those conservative treatments that were mentioned earlier.
You only have like 2 ablations a year and
Yeah.
3 steroid treatments.
Yep.
What are you going to do if they last only 6 weeks?
Yeah, and so there are options with that scope surgery. It's not in my talk, but there are options where instead of burning that nerve, you can actually just cut it, and it should permanently help with the symptoms. So that's certainly an option.
Thank you.
Of course. Any other questions? All right. So I'll show another case. So this is a patient, we talked about having multiple disc herniations. So this is a patient that unfortunately had now their 3rd disc herniation. You can see that a disc is bulging out on that bottom right picture. That disc is also pretty worn down. So this level up here shows what a nice healthy disc looks like. You can see that white fluid in the disc. Here you can see it's pretty thinned out, it's dark, and there's actually some swelling in the bone here and here. So this would be a patient that, despite having a disc herniation, they've had it multiple times, they have a worn down disc, they have swelling in the bone, they would probably benefit from doing a fusion surgery. So this, as a patient that we used a robot to do the surgery for, so we were able to plan the exact screws in the cage. Here you can see on the left and the right, the screws are going in the bone, and that cage that expands is placed right in the middle. Despite this being a fusion surgery, the patient went home 8 a.m. the next morning, just wanted to stay overnight because they were a little bit drowsy after anesthesia, which is normal. And as soon as they woke up, that leg pain that they were having from that disc herniation was completely gone. So, it's pretty remarkable, even with having a big fusion, that you can go home less than 12 hours after your surgery. And this was the size of their incisions, just barely 2 quarters. So now this is an example of another good fusion candidate. So this is a patient that had instability in their spine, again, from that fracture that line is pointing towards. 50 years old, severe back pain and pain shooting down the legs. You can see that fracture there, and you can see, again, this spondylolisthesis or shifting of the bones. You can see how this bone here is sitting slightly in front of this bone here, and this space here is very thin. That disc is pretty much gone. So this is an excellent fusion candidate. So again, using the robot, we placed this large screw in the center of that disc space. The rods and screws were exactly where we wanted them to be. And then kind of when you compare the before and after, so that area is where the nerve exits and goes down the leg. When that disc was collapsed and was shifting, that space isn't very large. But after our surgery, we were able to put that large cage in there, open that space up, and that nerve had a lot more space than it did before. So same thing, patient stayed overnight, went home the next morning. Back pain was still there, a little bit of stiffness from the fusion, but the leg pain was completely resolved. So at their 2-week follow-up, they were kind of back to doing all their normal activities. So this is another example. So again, when the age question can come into question, well, am I too old to have a fusion? This is a 78-year-old patient, very active, worked on a farm, had this severe disc degeneration at the L3, L4 level. You can see here, disc is completely gone. They had that spondylolisthesis or that shift again, and they were having both severe back pain and pain going down both their legs. The MRI kind of, again, shows that area where the nerves are very tight. Again, a normal MRI is on the right. You can see on the left here, really no fluid seen, and that ligament is really thick in the back. That's what that V shape is there. So they were having really bad leg pain, and that was their main complaint. So again, because of that instability in their spine, they were a good candidate for a fusion. So again, using the robot, we're able to plan our screws. This cage we actually put in from the side, so we did a lateral surgery. And I'll kind of show what that entails in a second. But if you look at their before and after, again, you can see that slip is completely reduced. The bone on the left is in that perfect alignment compared to the right. And that hole where that nerve exits and goes down your leg is significantly larger on the left once we've put that cage to open up that space. And again, 78-year-old patient, went home the next day. Came back at their 2-week follow-up and were back on the farm and were kind of doing more than I wanted them to do. But they were feeling good enough to kind of go back to those activities despite having a fusion, which in the past was a 4 or 5 day stay in the hospital and kind of multi-week recovery. And so we did this surgery in the lateral position, so the patient was lying on their side. We use a special retractor system, so we can do this through a very small 4-centimeter incision. This is kind of the view we have during surgery where we're looking directly down on that disc. We remove that disc and put that cage in the middle. And then just for a reference, that's how big the incision is. That's how the patient is lying for the surgery. And so for this patient, we were able to do this through a lateral incision and, again, 3-4 centimeter incision. And then sometimes we also see pretty bad trauma or fractures in the spine. And so, again, this was a patient, as you can see, has a very bad burst fracture. The patient fell from a ladder 12 feet high, landed straight on their back. They have this pretty bad fracture where this bone on the left here is completely crunched down. And you can see all the fragments that it's in on the right side. And so using our robot, we were able to place these screws and rods all percutaneously or through very small incisions. When you compare, this is what the fracture looked like before. You can see it's completely crushed down. And then here it's a nice big square again. And on the image on the left, the patient's kind of leaning forward. And on the right, they're nice and upright because those rods are holding them as that bone heals. And those are the incisions we use. So we can put these big rods and screws with these kind of very small incisions throughout. And then one last topic that I want to talk about is a specific type of surgery that I do for cervical disc disease. So similar to our lumbar spine, we have discs in our neck. Those discs wear down. They can cause pain, numbness, tingling, similar to symptoms in our lower back. And again, that's often due to disc bulges in the neck that pinch the nerve and cause pain down the arm. So again, that's called cervical radiculopathy instead of lumbar radiculopathy. Similar symptoms, pain, numbness, tingling, weakness in the arms. Similar to our lower back, they usually go in a specific distribution as each nerve goes to a specific part of our arm. And similar to the lower back, again, we go through our regimen of conservative treatment with physical therapy, anti-inflammatories, and steroid injections. If those don't work, Then we talk about the dreaded surgery, and there's different ways to do surgery on the neck. The main surgery that I do is all through the front, or an anterior fusion. And the anterior fusion in the neck has been around for 30, 40 years. It's a surgery that works very well, and it involves removing that disc and placing in the past a cadaver bone to get our fusion. But now with the advances of technology, we're able to put specific titanium cages or plastic PEEK cages, and then we put a plate with screws to get the fusion in the neck. So for this type of surgery, we go through the front, we remove all the dangerous structures out of the way, get right down to the disc, remove the disc, and accomplish our fusion. Again, the goal of the surgery is to take that disc out that's pinching the nerves in the arm, or excuse me, pinching the nerves in the neck, causing the arm pain. So while the surgery has been around for a long time and patients overall do very well, we know there are side effects of doing a fusion. And the biggest thing is limited motion in our neck. And when you fuse the bones in the back, the idea is you're taking two bones, fusing them into one bone. When that happens, the discs above and the discs below the fusion start to wear down faster. So those are kind of the two downsides of doing a fusion. You lose mobility and you wear down the discs above and below. And so, the question is, well, are there other options to a fusion? In other parts of orthopedics, we don't really ever fuse a joint. Knee replacements, hip replacements, shoulder replacements. We don't limit the motion of the joint, so why do we do that in the neck? Well, that led to the question and the development of a disc replacement. So similar to a hip replacement or knee replacement, we can actually do a disc replacement. And the idea of a disc replacement is we take the disc out, that's the main source of the problem, and instead of fusing it together, we place a mobile bearing implant where you still have all the range of motion in your neck, kind of side to side, up and down, while still accomplishing the goal of taking pressure off the nerves. So as these are all kind of different types of disc replacements, you can kind of see the same ideas there where there's a kind of center mobile core that allows you to still move, and so you're not having a stiff fusion in your neck. And this is not always, indicated in every patient, but for the correct patient, I think a disc replacement is a kind of a wonderful option. These are the two newer implants. I use the one on the right that was just approved in 2021. It has that kind of center core that allows for full range of motion. And it's great for MRI, so that's why patients say, well, can I get an MRI? I have this implant before. This is one of the best implants to have if you need an MRI in the future. So just show you a quick 2-minute video of kind of what this surgery entails. And so far we've done now 6 of these here at Frederick South. So, we start our patients are lying on their back for the surgery. We use an x-ray machine to know exactly where we are. Once we've done our dissection and gone down to the spine, we place these 2 pins in the bone to help open up the space so we can get to the disc. I remove that disc that's pinching the nerves, and that's the most important part of the surgery. Now that the disc is out, we obviously have to put something in there. So we open up this space and measure exactly how big our implant's going to be. We have special trials that we use to make sure that we put the appropriately sized implant in each patient. So once we trial this and we have a size that we're happy with, we then use a special instrument to cut a little tract of bone so that we can place this implant in there. So this is just making that space for the implant. And now we're just loading it up on this special instrument. And then that metal groove on the top of the implant, that's what actually grows into the bone. And then that center core is what allows you to kind of have that range of motion back in your neck. So now we're kind of do our final tamping of the implant into that disc space. And then once we're all done, ideally without a fusion, you have that full range of motion throughout that entire implant.
Do you only do that with the neck then, not with the back?
Correct. So there are lumbar disc replacements. Their outcomes haven't been as good as the cervical. And it's a much more invasive surgery, so I personally didn't train on doing them. I personally don't do them. Yeah. But there is an option to do that, but the indications for that are even less than the neck. So I'm just going to run through 2 very quick cases. So this was a 38-year-old patient, has this disc bulge on the left side at the C6, C7 level, had weakness in their arm, weren't able to work because of how bad the symptoms were. But kind of given their age and the fact that this was only at 1 level on their neck, I felt that it would be a good candidate for a disc replacement. So this is what the implant looks like on x-ray. All you can really see is that kind of ceramic core in the center. Right after surgery, the arm pain was completely gone, and before their 2-week follow-up, they were back to work, kind of full strength. Everything was just like it was before their injury. And then one final example, again, this is a 37-year-old patient, 4-year history of left arm pain, so I'm impressed that they were able to last that long. But you can see this big disc herniation right where that nerve exits. And then here you can, on the left side, you can see where that disc is bulging out. This is a different type of disc replacement, but the same kind of idea. Again, few hours, not even right after surgery, when they woke up from anesthesia, that arm pain they had for 4 years was completely gone. They came back at their 2-week follow-up, were doing fantastic, and said they wish they had done that 3 years before. So never too late to get this taken care of. And this was the implant we used for this surgery. So in summary, lumbar and cervical spondylosis is unfortunately a very common thing that millions of people kind of suffer from. Symptoms that we talked about can be low back pain, neck pain, leg pain, arm pain, numbness, tingling, weakness, etc. And there are unfortunately multiple minimally invasive ways that we can kind of address these problems, and with the goal of kind of minimizing pain and increasing recovery, and try and do these surgeries on patients that maybe in the past would not have been deemed a safe candidate. But as you've seen today, I can do these surgeries on people as old as 93. Thank you. Any questions? Yes. Sorry. Yes.
Will the MRI show how many areas in the spine where there are fixed nerves?
Yep. So yeah, for neck MRI or lumbar or lower back MRI, that'll show all the areas where there's potential problems. One of the things I commonly see is, as we get older, our disc will bulge. So if you get an MRI, there'll be disc bulges, there'll be stenosis. The biggest thing is trying to see what the MRI shows and then what symptoms you're having, right? So if your pain is going down the leg on the top of the foot, then I know there's a specific nerve that's probably causing that. If there's a big disc bulge there, then we can address that with the injections and if needed, potentially surgery. But yes, the MRIs will show me every area where you have a potential disc problem.
So even, okay, let's say you cut the nerves in the facet joint.
Mm-hmm.
So then even as the arthritis progresses, it'll be fine, right?
Correct. So at that specific level, yes, because that nerve is what takes the sensory signals to the brain. So if it's cut, even if that arthritis gets worse, it's not really going to be able to tell the brain that it's hurting more.
Okay. So there's really no downside to that.
Correct. The only downside is, in the very rare case, those nerves, even if they're cut and burned off, they somehow grow back together, which can happen, but it's very rare. Yeah, that's the one downside. Other questions? All right. Yeah, yes.
When a doctor talks about spurs
Mm-hmm.
on their spine,
Yes.
like a spondylosis,
Yep, so that's a spinalosis, and I'll...
do they do anything specific for spurs?
No, so I'll pull up this picture here. So this is kind of what they're talking about. A bone spur is just extra bony growth, and that happens because of arthritis. So when you have abnormal motion in the body, it doesn't like that, so it wants to fuse on its own. So that's the idea of the bone spurs. So it tries to do what I do with surgery. It tries to fuse itself, and that's why you develop bone spurs. It's the same idea, exactly, except for in your spine. Yeah, same idea.
Doctor, what if you know there is a cyst in your spine and you haven't removed it? Does it grow bigger over the years and it cause trouble?
So if the cyst is from the facet joint, it can certainly get bigger. And if the cyst gets large enough, it can pinch the nerves in your back. So there are patients I've done surgery on where they have a facet cyst, similar to like a Baker cyst in your knee. That cyst pinches the nerves, then we do have to remove it, and so that can certainly happen. You can have a cyst and have it not pinch the nerves, and that's okay to watch, but once it starts to have problems, then that's something we can potentially address. Yeah, absolutely. All right. Thank you again, everyone. I appreciate your time today.